Thank you, Beth, for organizing this. Tom, Dr. Sharma, and my physician leaders, Dr. Krishnamurthy and Dr. Kinney, who have been helping me with the STEMI app and my work in the STEMI throughout the health system. So today, I'm going to talk to you about the system management of the STEMI patient here in the Mount Sinai Health System. These are my disclosures. So basically, I'm just going to talk about the agenda. This is my agenda, that we're going to talk about the definition of STEMI, the treatment, why treatment is fast, the management of these patients and the challenges that we have to take care of STEMI patients, how we as a system take care of STEMI patients, and what we did internally with the STEMI app. So what is a STEMI? It's a highly time-sensitive medical emergency, and it's associated with a transmural myocardial injury associated with necrosis of the myocardium. It's triggered by an acute thrombotic rupture of a vulnerable plaque in the coronary artery. Patients typically present with chest pain, and our goal is rapid diagnosis and rapid treatment. So just to review, this is an EKG, and you could see in lead 2, I'm pointing at the STEMI, you can see ST elevations greater than 1 to 2 millimeters outside of the isometric line, and that's the AHA-ACC HRS definition. So why is time to treatment so critical? You guys probably all heard the word time is muscle, and the longer you wait, the mortality increases. And if you look at this chart on the right, it's a little bit complicated, but if you look at the time, or the red curve, which is patients with shock and that didn't have out-of-hospital cardiac arrest, the mortality nearly doubles after another hour of treatment, of delays in treatment time. So immediate coronary angiography with the intent to perform PCI is actually a class 1A recommendation for patients that do have STEMI. And as I said, treatment delays increase mortality, particularly in patients with cardiogenic shock. And because of this, many institutions have stringent performance time metrics, particularly from AHA, ACC, where STEMI receiving centers have to do these life-saving reperfusion therapies in a certain amount of time metric. And they're actually pushing for us to bypass the emergency department completely, thus saving some more time. So in summary from this slide, the time from the first medical contact to the primary PCI is a strong predictor of adverse outcomes. So the sooner you do it, the better off the patient is. So this is a STEMI on angiogram. So this is a patient that had anterior STEMI. You could see that the LED is missing. It's hard to see if you don't look at angiograms, but this is the post-angio on the right, where you can see that they placed a stent. So the recommendation, there's a lot of recommendations that AHA and ACC have, and there's a lot of challenges that we as a hospital and the health system have to also deal with to manage these patients. STEMI patients are very sick, they're unstable, and there's a high expectation for a rapid transition of care. So whether it's ED to cath lab, field to cath lab, floor to cath lab, outside hospital transfer to a STEMI receiving center, and then getting these patients out of the cath lab to the ICU. They're very sick patients. There's a focus on early cath lab activation, pre-hospital activation, which we do participate with FDNY and 911. And the big push is to minimize ED time with a preference to bypass the emergency room. And as we know as nurses and working on the floor, that the transition of care and making sure that these patients move safely from department to department is the most pinnacle. I mean, we're all about safety. So obviously having a streamlined communication and working fast so that we can avoid clinical deterioration with cardiogenic shock and cardiac arrest. And in fact, AHA is pushing for very stringent systems of care for timely management, where they want a single call approach, where basically you push one button and then the entire team is activated. And our metrics for this, for those that don't know, door to balloon, which is when the patient enters the door in the emergency room, up until we open up the blockage, is 90 minutes. So it's a very fast transition. For transfers, it's 120 minutes. And as a health system, to make sure that we're doing our part, we do participate in quality registries. AHA get with the guidelines, Mission Lifeline, STEMI, ACC, NCDR, and our New York State Department of Health PCI report. So as a system, we had to create systems of care to make sure that these STEMI patients can be identified and taken care of appropriately. So here in the Mount Sinai Health System, we have 3 STEMI receiving centers, which is this institution, Mount Sinai Maine, Mount Sinai Morningside, and Mount Sinai Queens, just recently. For those hospitals that don't have a cath lab, like Mount Sinai West and Mount Sinai BI, we had to figure out how we can manage these patients and get them the appropriate care when they walk through our emergency department. And we do, like I said, we do participate with FDNY, so there is appropriate triaging and routing so that these patients can be brought to a STEMI center. So if you could see the animation, we have our transfer pathway of Mount Sinai West to Morningside. This is before Queens to main campus for when their cath lab is available before our old pathway. And now locally, Queens is also doing their own cases. So to do this and to make sure that we are communicating with each other and all the teams appropriately, we designed our own app, a novel application to kind of streamline communication between all team members and that single button activation that AHA is asking for. So we began this initially as our pilot from Mount Sinai Queens to Mount Sinai Main, and we've scaled from Mount Sinai West to Mount Sinai Morningside, and now we're doing it locally at Mount Sinai Queens. And this is basically an interfacility, multidisciplinary collaboration between the ER doctors, the nurses, the cath lab physicians, the cath lab nurses, technicians, and the ICU. The biggest benefit of this is that we have real-time ECG transmission directly to an interventional cardiologist on call, streamlining STEMI recognition, which, as I said, the quick time to identify and diagnose. For those patients being transferred, we have GPS tracking for the ambulance, so we know exactly where they are. And we have a secure HIPAA-protected team messaging with faster response time, enhanced communication efficiency, and we do have improved patient outcomes, which I'll show you briefly at the end. So implementation of an app is not easy. There was a lot of people that are involved, identifying key leaders, having meetings with department leads, coming to different units to come train, running a pilot, looking into the cases and evaluating each and every case to see what went wrong, what went well, and how we can improve. And the outcome shows improvement of treatment times, and seeing positive feedback from users was also important to us, and it's a motivating factor to why we're doing this. We also have a lot of challenges with mobile application implementation. So widespread usage, the more users that are on the app, the more people that we have to get onboarded. Uptime, making sure the app works, data security compliance, and of course, everyone wants more. EHR integration, artificial intelligence, scalable architectures for other emergency pathways. So this is just a sample workflow. This is a patient that came from Mount Sinai Queens that needed to, with chest pain at 3 o'clock in the morning, and actually this is before they had their cath lab, and needed to be treated for STEMI. So EKG was done quickly, showing ST elevations and anterior leads. Patient's history is hypertension and smoking. So EKG was done at 3:05, just 5 minutes after they walked in. Immediately, once the emergency physician doctor saw the ST elevations, they can raise a case in the STEMI app. They can take a picture of the EKG, give us the name, date of birth, their callback number, and the first medical contact so that we know how we can get in touch with the patient, what we can do, the location of the patient. A clinical discussion happens immediately in the app as soon as the interventionalist is notified that there is a potential STEMI. And when this case is accepted, the ambulance is also simultaneously dispatched to save time. So once the clinical discussion is complete and the case is accepted, a single press for the interventionalist can now bring almost 10 providers, the entire cath lab team, the ICU, into the loop. So this is really great information. As you can see, the patient walked in the door at 3 a.m. and now 14 minutes later, there's a full diagnosis and treatment plan. So like I said, very rapid transitions of care. We have a HIPAA-protected secure chat where all the key members are all brought in so that there's always constant communication among the team members. There's this cardiogenic shock screening and also what medications were given. And again, an open communications between our referring teams, our accepting team, the transfer center, and the CICU. There's no surprises when we see these patients. The EMS is tracking exactly, we could see where the patient is, and a status tracker also gives us an overview of this entire process. So this is, in this angiogram, you could see this is a patient that had the anterior STEMI. You can see the LEDs missing in the pre and the post was treated. Our door in was 3 a.m. and our device time, this is once we opened up that blockage was at 4:22. So to summarize, this patient had a 1-vessel CAD with 100 total mid-LED. We treated it with 1 stent. He went to the CICU. Our door in, door out time, which is the time the patient reached Mount Sinai Queens and then got out of Mount Sinai Queens, was 42 minutes. Our goal is 45 minutes. So imagine just transferring a patient from one hospital to another. We're doing this ideally in less than 45 minutes. Travel time was 24 minutes, and from arrival to device, we commend our cath lab team was 16 minutes. So overall, our door-to-device time on this particular case was 82 minutes, which is less than the 120 minutes required for transfer patients, and it's even less than the 90 minutes for our own internal patients that walk into the ER. So real quick, just some outcomes that we have from our pilot. The US average is actually quite low for transfers. It's probably around 18%. Mount Sinai and Mount Sinai Queens wasn't so bad. It was about 72%, but we reached 100% of our post-op metric after app implementation. Our door-in, door-out time averages also decreased 68 minutes down to 52 minutes. And same with door-to-device, 120 minutes down to 91 minutes. This is a national registry, the ACC-NCDR, where it basically compared Mount Sinai with the entire nation. So looking at from 2021 quarter 4 to 2022 quarter 3, the in-hospital death of STEMI patients was quite low, 0.3% versus 2%, which is very impressive. So we know the app works, we know that the fast teamwork works, and that the open line of communication that we're doing this safely. So my key takeaways is that the current transfer process for STEMI patients has several limitations and risks associated with delays and complications which can have significant consequences. And leveraging streamlined communication tools like the STEMI Cath-Aid among STEMI team members significantly enhances diagnosis and prompt treatment of STEMI by improving communication between healthcare providers and resulting in measurable improvements in patient outcomes. And just before I finish, I just want to thank everyone that has helped us here at Mount Sinai Main Campus, Mount Sinai West, Mount Sinai Morningside, and Mount Sinai Queens. Thank you very much.